Good afternoon, everybody. Welcome to Grand Rounds today. Today I have the pleasure of introducing Dr. Susan Sgambati. Dr. Sgambati is boarded in general surgery and colorectal surgery. She is a clinical instructor at the University of Colorado in the Department of Surgery, and she's also medical director at COPIC in the Department of Risk Management and Patient Safety, and she has very kindly accepted our invitation today to provide us with a review of opiate prescribing for surgeons. And please join me in welcoming Dr. Sgambati.
Okay, thank you very much. I hear that applause. Very gracious of you. Well, welcome, and I hope you're having some lunch and can sit back and relax. I do have some questions for you, so please don't speak with your mouth full. But otherwise, without further ado, as introduced, I am a surgeon. I recently retired and I'm doing this full time for the past 3 years at COPIC. What we're going to talk about today is give you a little history of how we got here with these opioid requirements, like what spawned it, et cetera. Look at what Iowa board requirements are and the CDC's guidance. Okay, they're guidelines, they're not requirements. And then hopefully set you up for our second hour of enduring education, for which you can get CME accreditation and your opioid hour, which is called the Opioid Crisis Strategies for Reducing the Burden. And that's kind of like part 2 of our continuing education on opioids, because we know you need the hours for your attestation for your license. So I'm going to go through these basic CME requirements for your point. I have nothing to disclaim. This would be good for 1 hour of CME credit, and levels of evidence we used are adapted from the American Academy of Family Physicians, level B. Now, what do we want to look at today? Well, we want to talk about, as I mentioned, the history of the opioid crisis here in the United States, demonstrate an understanding of opioid prescribing standards, okay, around dosage, formulation, and duration, articulate how you would access and utilize CDC's recommendations, and discuss common signs of opioid use disorder. Now, the real reason you're here, I know, is they don't even give you free lunch anymore. You have to demonstrate that you, not demonstrate, you have to attest that you took 2 hours for Iowa of training, and then the DEA requirement is 8 hours of education to renew your license. Now, there are several ways to meet this. So obviously, this is a structured talk dedicated to opioid. But if you are involved in any peer review with opioids, if you're doing any kind of service volunteering, you went to a conference and heard something with opioid content in it, or you gave a presentation to a group, you can also put that down as I participated. Now, again, you have to attest to your compliance. And what does that mean? Well, it means you took it, write it down somewhere in your phone or something. And if you're audited, you need to demonstrate that you did that. No one's going to, when you go get your license, ask you, did you, can I see your certificate from those trainings? You're just attesting. It may be important in a med mal situation if there is some sort of negligent prescribing allegation that a plaintiff's attorney could ask for demonstration that you did this education. And again, the board is the one your board of medical examiners is the one who is going to want this information. So without further ado, how did we get down this rabbit hole? Okay. Any ideas? I'm sure you have some. I'm sure most people have seen at least something on Netflix or something about the opioid crisis, et cetera. And yes, there are quite a few factors. Historically, morphine was isolated in 1806. And just as a point of review, I know we know this, but it might be as far back in your head as it is in mine. An opioid is a substance that by definition binds to about 5 receptors. Its most profound effect is on that mu receptor, and that's where we get the analgesia and the euphoria from it. Oh, and that also is why it's highly addicting. We used this abundantly in the Civil War and managed to get hundreds and hundreds of soldiers addicted. And they used to call opioid addiction a soldier's disease. In fact, this probably was the U.S.'s first opioid epidemic. Something about the word opioid, we should be using it as instead of narcotic. Narcotic is a word that is derived from the Greek numbness or sleep, right? But in our vernacular, it's an American legal term, and really it's used by law enforcement, and it applies to just about any illegal or controlled psychoactive drug. Okay. Then heroin was synthesized, and this was thought to be a non-addicting morphine alternative. The same year, aspirin was synthesized. And interestingly, if there are any chemistry nerds out there, both of these substances were synthesized in the same way. That is, they took a chemical that exists in nature and they acetylated it. So by putting that acetyl group on it, created these synthetic drugs. Both were marketed by Bayer. Heroin, this is the actual bottle and its actual brand name, was marketed as a cough suppressant and a morphine substitute. The term heroin, the word I should say, was derived from the Greek word. I have no idea how to say it, but you can see hero is in there. And it actually does mean heroic, but it loses a little bit in translation because it's supposed to convey a sense of something extremely omnipotent, powerful, and potent kind of thing. And then, as we know, 1970 FDA said that's a Schedule I drug. And what does that mean? It has no medical use. So no known medical use for heroin. So we can fast forward up to our present day. We recognized these people in our world, all of whom died of opioid-related deaths. It's not just limited to movie stars, as we know. This is from social media. I don't know if you ran across these. These are probably about 6 years old. The pictures of people ODing in front of their children. In fact, that younger couple OD'd in front of the little baby on Christmas Day. And this is, on Instagram type of thing. Now you might say, okay, Sgambati, what does this have to do with us? Okay, those are heroin addicts and I'm a surgeon. So what do I have to do with this? So let's take a look at the data, okay? And you've probably seen some of these. This is a little more up to date going up into 2021. These are deaths by, on the left, any opioid, okay? And then on the right, the type of opioid. What is remarkable here, and I'm sure you've heard, that the blue line, navy blue line, is synthetic opioids, other than methadone. And obviously that's the fentanyl-laced stuff that is now really taking off with the epidemic. So our bottom line is deaths continue to go up. But while death may be the ultimate equalizer, there is a huge downstream problem as well. For every death, there are about 10 treatments for abuse, and that goes on to ED visits for abuse, people who are dependent, and then people who simply abuse it. Okay, so there's lots and lots and lots of downstream problems related to this. So where did we lose control? And I say we, I don't really mean the government. It's kind of like we prescribe these things, and how did it get so out of hand? So let's take a look at what we learned, okay? We were originally taught it's okay to prescribe opioids for legitimate pain, right? That was the term. We're surgeons, we create pain. So we're going to have to use opioids to manage our patients. This is and I put quote marks in literature that was referred to. And this is just a letter to the editor in the famed New England Journal of Medicine from 1980. And it essentially states that in their experience in Boston with about 12,000 patients, no one's randomly, randomization, nothing. They vaguely tracked these patients, and the instance of opioid addiction was exceedingly low or, quote, rare. So that kind of became our literature. And then it came out, the mantra was opioids are not addictive when prescribed for legitimate pain relief. And that was kind of pharma's line on this. Then, I know we all remember this, pain was told to be the fifth vital sign. And these were in every room. And you were really encouraged to get people to have no pain. And in fact, JCO made that one of their, goals in 2001, pain-free patients. And then what you might not know about this is this whole thing, I was always under the impression that JCO is the one that pushed this in the hospitals. No, if you follow the money, this was designed by Purdue Pharma. And, Netflix has a very nice Dope Sick show based on Empire of Pain, or maybe it's on Hulu. And then they have Painkillers and all those other shows there. That's where you find all these kind of interesting information on the origins of why this came into our hospital system. But the subtext was if there was pain, then you treat it with opioids, or you're really not a modern, well-trained, compassionate physician. In fact, the Institute of Medicine had a report also that pain relief was a moral imperative and a national priority. Now, again, back to this. Does the doctor treating this patient's fracture have anything the pain from this fracture have anything to do with the current opioid crisis? Well, the answer is yes. Right? The critical concept is that the majority of people with chronic opioid use disorders, that's abuse and misuse, were originally prescribed opioids by a physician. It's an important concept. I'll say it again. The majority of people with chronic opioid use disorders were originally prescribed opioids by a physician. Okay. Now, let's look at the relationship of acute pain management to the opioid crisis. So, what percent of heroin users that have started with a prescription opioid? If you had to take a guess, you'd probably say a lot. But did you know it was 80%? Okay. That's like, 3 out of 4 heroin users started with one of our pills. And then what percent of chronic opioid users got their first dose for free? And when I put the air quotes on free, I mean a friend, a relative said, here, we got some of these. This will help you out. That's 65%. Okay. Now, where do they go to get this for free? Well, it's in the medicine cabinet. The percent of prescribed opioids that go unused is 75%. So we might be over-prescribing them. And then 92% of patients have leftover pain pills. Now, what percent of patients keep them? Well, I think people are more prone to throw out their extra like Lasix or losartan than they are to throw out their pain pills, right? 80% of patients keep them. So this is really where 65% of the heroin users get their first free pill. So we do have a role in this. So let me ask you to think about it. When you're prescribing, how much do you give and why? When I had to think about it, I started giving this talk maybe about 5 years ago or so. I was like, well, that's what I saw my attending do, and it seemed to work well. I never saw his patients back in the ER because they were in pain, so I guess it's all right. So it was like a number like 40 pills we gave for hernia, whatever it might be. Historically, we obviously prescribed too much. The opioid requirements, even for surgical procedures and long bone fractures, are much, much less than we were led to believe. This has come out in the recommendation of just prescribe the quote minimum amount that's necessary. Some data to support that. JAMA did a study a few years ago that found 80% of patients could be treated with 5 pain pills that to cover most acute painful situations and post-op. But for intra-abdominal and hernia procedures, it went up to 15 pills. So if we split the difference, we're somewhere around 10 pills is what each acute episode at most requires. So I think it's still a lot less than my average prescription used to be. I did change. One big change was, I performed a lot of hemorrhoidectomies, which, as we know, is probably one of the most painful procedures you can ever go through in your life. And we were really able to significantly decrease that, the amount we gave, and get ourselves kind of in the normal range of prescribing by, of course, using alternative treatments and educating the patients on this. Now, here's our next critical concept in this. What is the chance you'll be on opioids in 1 year if you take 10 days of oxycodone? Okay, oxycodone, not OxyContin. It's about 15%. And that's pretty scary, right? And why? Why is this? Well, duration of use, not the dose, is the strongest predictor of misuse. I'll say that again because it's another one of the critical concepts. The duration of use, not the dose, is the strongest predictor of misuse. So here's a study that examined post-surgical prescriptions for opioid-naive patients over several years. And you can see that the longer you are on it, the higher probability you have of continuing use at 1 year and even at 3 years. This backs up the CDC's finding that there's a direct correlation between the number of weeks of initial use and the likelihood of misusing opioids. So an opioid naive patient after 10 days has about a 20% chance, close to be using it in 1 year, which is a little frightening. Another bit of data, it's refilling it is also going to cause problems. Each additional week is associated with another 20% increase in misuse. So it's pretty profound numbers. Excuse me. Now, I did not make this, but the CMO did actually, and I really like it, even though it's not as sophisticated as we tend to use. But really what it shows is that, first of all, everyone has a threshold. And And even a chronic pain person has a threshold that once you pass that, your pain reduction is not any higher, but the risks go way, way up. And risks for overdose, death, and ongoing use disorders. So now what? What are we supposed to do about this? Well, the CDC has proposed some guidelines, and they're very, very general. I've outlined those, and we will go through some of the other points of their guideline so that you're familiar with their existence. But I think they're a bit too sweeping to use in an everyday surgical practice. This first one, prescribe immediate release opioids instead of extended release or long acting. I hope that never enters into your mind for the management of acute surgical pain. No one should have a fentanyl patch slapped on them to manage their cholecystectomy pain. Okay. Prescribing, number 2, the lowest effective dosage and no greater than quantity than the anticipated need. Well, you know what they need because you know what you performed on them, and you've been doing it and you have an idea. I don't think the CDC is going to dictate that for us. Obviously, we would evaluate the risks and benefits before any refill. And furthermore, number 4, any increase in dosage, I feel mandates you seeing that patient and not doing that over the phone. Because you really, if they're deviating a little bit from what you usually do, you really want to know, is something else going on here? Early infection, don't know. And then obviously number 5 kind of goes back to this. There is a point of diminishing returns and increasing risks. And so we avoid increasing a dosage above that. CDC also has us determining whether or not to initiate it. I know there have been some great strides. The ERAS protocols and things like that do truly help minimize opioid use in the post-op period. At least in colorectal surgery, they were phenomenal. I saw some good results in orthopedics too. The selection, we talked about that, long acting, et cetera. Deciding duration of your initial use and the follow-up. And then finally assessing risk and addressing a potential harms of an opioid use disorder. These guidelines apply to the outpatient 18 years and older. And while I know we don't really dabble in the chronic pain situation, occasionally our acute can transfer into a subacute situation, and you have to know when things are getting a little risky for you and your patient, and how to refer them on for management, because it's kind of getting out of your wheelhouse. Another way of saying that, we used to have a great slide that said, if you can't land this plane, don't take off. Okay, so if you're getting into some scary numbers of opioid prescribing, don't do it. Refer on. There are exclusions. Most notable for us is palliative care, end of life, and cancer care. And they're intended to be flexible. If you want furthermore, there's a huge document you can look at and just Google CDC opioid guidelines, guidance rather, in 2022. So what is going to help you not draw attention to yourself? And we call these kind of bright lines. Lines in the sand that if you are prescribing over these guideposts, you will draw attention to your habits. These are adapted from Colorado's recommendations back in 2018. I don't see states, particularly Iowa, we looked, couldn't find any numbers to this effect, nor does the CDC give you guidelines. But I like facts, and I find this a very useful slide. I hope it helps you too. So once you get opioid doses, or you're prescribing over 50, and it's a lot, 50 morphine milliequivalents per day. It is dangerous, and because there is a higher death rate in patients that are on those dosage. Patients who do not get pain relief from opioids after 30 days are very unlikely to get any pain relief 6 months out. So if they're still on 30 days and asking for refills, a little light should go off in your head and say, what's happening here? And what is our end game, right? And then finally, we know that prescribing opioids for over 90 days, it substantially increases the risk for an opioid use disorder. Now, what should be in your toolbox in managing this? Well, quick word on the PDMP. I'm going to throw out there how many states have one. All of them. And they talk to each other. So in Colorado, I can access Nebraska, Iowa, Wyoming for sure, and to see if things are prescribed in other states and by whom. In addition to, they can look at mine. Calculating morphine equivalent dosages and assessing risk. Why would you do this? Okay. Well, sometimes, you get patients who are on heavy duty doses, and I always was worried that I wasn't going to give them enough. Well, this is an app, everyone's got their phone. You have an app, you put in what they take, and you have a kind of an idea of where they stand and what you would need to give for post-op pain relief. But additionally, you're minimizing, obviously, their risks of misuse, and you're demonstrating your awareness of what is going on, what you need to prescribe, and how you can mitigate your risk and the patient's risk of having a problem with the opioids. So essentially, it really makes you look good and you're on the ball. A quick word, benzodiazepines and opioids. The FDA issued a black box warning on prescribing the both of them together in 2020. Does this mean you can't do it? No. It means that you have to have a thoughtful conversation, perhaps, and document this in the chart that you had this, and just be very cautious. Why? Well, the data again shows there's a 10-time risk of a fatal overdose versus just using an opioid alone. Furthermore, COPIC has a very difficult time defending you if you did that without addressing it somewhere, that you were aware of the risk and you shared that risk with your patient and their caregivers. Late in 2020, the FDA issued a further notice on benzos alone. They urge caution in prescribing just benzodiazepines. They called them intrinsically addictive with a high abuse and misuse potential, and physically addictive and have withdrawal symptoms. And so, again, when you have that post-op patient with anxiety or cramps or things like that you're trying to alleviate, think twice about what you're giving and what you're prescribing concomitantly with your opioids. Now, move on to the opioid use disorder. Which of these, can you pick them out in this lineup, has the opioid use disorder, or which of them? It's actually a trick question because they all do, and they look just like you and me. So you might think, how do I, what's a guideline or a tool? Well, if we go back in the recesses of our brain to the DSM, now it's DSM-5 criteria. This is a defined disorder, and if you have 2 of these in the past 12 months, you have an opioid use disorder. So overuse unsuccess in cutting down, lots of time spent thinking about it, etc. So you look at that and go, well, how would I even ask these questions? I'm going to replace their knee. And a simple, it really is, have you ever used opioids for anything other than what you were prescribed for? Or do you have any left over at home or those kind of things? Well, tell me about the last time you had surgery. Was there an issue? It's a nice broad question, non-accusatory, etc. And you kind of took a look. Certainly if your suspicions were up, these are some questions you could ask as well. And I'm going to kind of start to wrap things up. I would like questions, but I think I want to go over the big takeaways for you as surgical providers and the guidelines. First of all, beware of those bright lines that draw attention to you and to your patient as we're getting into a little bit of dangerous waters here. And they surround the dosage, the formulation, and the duration of use. So we looked at the 450 morphine milliequivalents, the long-acting continuous release formulation as a no-no, and then duration. Remember, duration is the highest predictor of opioid misuse. Next, polypharmacy. Be cautious, again, when you add Valium for muscle spasm, patients whose pain is hard to control, as well as those who experience anxiety and things like that. Also, I think, just renews your efforts to make sure, is something else going on here? Namely, am I missing something? A compartment syndrome? I don't know. But take a deeper look into what the patient looks like before you just add this on. You use your PDMP. It shows due diligence, and often it's been eye-opening, put it that way, particularly with out-of-state patients. Screen for the high risk. I know we've all heard these excuses before, right? But when you hear it, go a step further and say, well, have you ever had a problem with this? Do you have stuff at home? You can mention a toxicology screen. That makes people bristle, even if you don't intend to do it. It does tend, if they know what you're talking about, you have a problem. And then finally, I think the real bottom line here is have an honest discussion. Most patients are aware now that there is an opioid problem and that you are being a good steward and a good doctor by having a conversation with them about this and their use or your perceived misuse of it. And then really recognizing anybody, and I mean anybody, can have this. It's kind of like an alcohol use disorder, similar lines. They are functional people until you get into a situation like this, a surgical situation. That's really the content here, but I do want to take a few moments and let you know what's available from COPIC for your ongoing pursuit of the requirements for renewal of your DEA and your Iowa licenses. We have this is right up on our website if you log in. We have what your requirements are. There's a resource list of CME opioid education that we provide, as well as courses you can take on your own computer, on demand, on your own time. And we have a podcast entitled Fulfilling Opioid Education Training Requirements with our CMO and our Director of Medical Education. And it's a quick 15-minute listen to, on your car ride home about how you can go about getting the various ways you can go about getting these. And then finally, we have this list of additional resources outside of COPIC from many organizations to help you with your hours. And most of these are free of charge. So with that, I'm going to kind of wrap that up, and I'd like to open up for any questions or concerns you might have regarding content or anything I spoke about. And I'm trying to see if I can get. Stop presenting. How about that? Okay, there we go. Not many people in the audience, but I have just one window of it though. So any questions or concerns, or can I help you, track down other methods? If you would be interested in obtaining another hour of opioid education over your lunchtime, we can do part 2 of opioid prescribings. We call it part 2. This is part 1, which is the basics and how you got here. And then part 2 is a little bit more of alternative to opioid therapy, and a little deeper dive into how do I get someone off of them if I've prescribed or they come to me with high dosages. So any thoughts on that? All good? Ken, is he still there? I can't see.
Yep, I'm here.
Okay.
Not seeing any questions in the house.
Nope, I don't see any in chat either. No. Okay, well, I will give you a gift of time, and thank you for your attention, and have a nice afternoon. Take care.